All right, welcome to The Explainer. Today, we are diving deep into one of the most formidable challenges in all of orthopedic trauma, fracture-related infections, or FRI. This is the kind of thing that can take a routine injury and turn it into an absolute marathon case. So let's get right into it.
So what if I told you that healing a broken bone isn't just about mending bone? What if it's actually a microscopic war? That's really the reality of a fracture-related infection. The patient's body isn't just healing, it's desperately trying to defend itself against an invisible siege, where the battlefield is the surgical implant itself. And the enemy? Well, the enemy builds fortresses that are almost impossible to penetrate.
Okay, so if we're going to win this war, we absolutely have to understand the enemy's fortress. And that fortress? It's this incredibly complex, living structure we call a biofilm.
Now, this is a really crucial point. An FRI is not just some simple surgical site infection. The international consensus now defines it as a distinct biofilm-driven disease. And look, that's not just playing with words. It fundamentally changes how we diagnose and treat these cases. It moves us away from these vague terms like osteomyelitis and gives us a precise, actionable framework to work with.
So this modern framework, it really gives us a clear path. Think of it like this. On one hand, you've got these confirmatory signs. We're talking about a fistula draining to the skin or seeing pus coming from around the implant during surgery. These are what we call pathognomonic. If you see one, the diagnosis is made, period. Treatment is mandatory. But on the other hand, you have suggestive signs, things like unexplained fever, or maybe inflammatory markers like CRP that keep creeping up. These are the clues, the red flags that tell you, we need to investigate this further.
So how does this fortress even get built? Well, it all kicks off with what's called the race to the surface. It's literally a sprint between bacteria and the patient's own cells to be the first to colonize that new implant. If the bacteria win, they anchor down, going from free-floating or planktonic to sessile. Then they start secreting this protective slime, an EPS matrix. This stuff is like a shield. It physically blocks immune cells and antibiotics and allows the bacteria inside to just hunker down in a dormant, highly protected state. And that brings us to this number, 1000x. This right here is the absolute heart of the treatment challenge. Bacteria living inside a biofilm can be up to 1,000 times more tolerant to antibiotics than their free-floating cousins. Now, this isn't classic genetic resistance. It's a phenotypic shift. It's a physical and a metabolic defense that our standard laboratory tests they don't even see it.
Okay, so we know what the fortress is. Now, how do we actually gather intelligence on it? Because, proper diagnosis isn't just about confirming there's an infection, it's about knowing exactly who the enemy is, so we can tailor our attack and not just fire blindly into the dark.
The gold standard for this is meticulous, and for good reason. First things first, superficial swabs, they're basically useless. They are so unreliable because they usually just pick up skin bugs, not the real culprit deep inside. The proper way to do this is to take at least 3, ideally 5, separate deep tissue samples right from that implant-bone interface. And you have to use a fresh, sterile instrument for every single sample. And most importantly, you do this before any antibiotics are given in the operating room. You have to get the best possible chance of figuring out what's really growing in there. But even with perfect sampling, sometimes standard cultures just come back negative. That's where these advanced tools come in. Implant sonication. It's pretty cool, actually. It uses ultrasonic waves to literally blast the biofilm right off the removed hardware, which frees up the bacteria so we can culture them. It's way more sensitive than just culturing tissue. And then you have next-generation sequencing. This is a culture-independent method. It analyzes all the microbial DNA in a sample. It's like taking a census of every single microbe in there, even the ones that won't grow in a dish. Now, this right here is a really, really important concept. It's this major disconnect between the lab and the patient, and it's why a lab report can, for all intents and purposes, lie to you. See, our standard lab tests measure what's called the MIC, or minimum inhibitory concentration, but they test it against free-floating planktonic bacteria. So the report might come back and say the bacteria is susceptible. But in the real world, the concentration needed to actually kill that same bacteria inside its bioform fortress, the MMBC, is orders of magnitude higher, often at levels that would be toxic to the patient. This is exactly why an antibiotic can fail even when the lab report looks great.
And all of that leads us right here, to the counter-assault. Because fighting FRI isn't about just writing a prescription. It's a full-blown, integrated campaign that requires a joint command.
Look, you just can't win these battles alone. Success is pretty much impossible without a dedicated team, a true multidisciplinary command center. You need the orthopedic surgeon to manage the bone and the stability, the infectious disease specialist to guide the antimicrobial therapy, the plastic surgeon to handle the soft tissue, and you absolutely need the clinical microbiologist and the pharmacist providing their critical expertise. The data is clear. This collaborative approach means fewer surgeries and much lower rates of treatment failure.
And that brings us to what might be the single most important principle in all of modern FRI management. I want you to really let this one sink in. In the battle against biofilm, the scalpel is mightier than the pill. You simply cannot medicate your way out of an established biofilm on a piece of hardware. The cornerstone, the absolute foundation of treatment is surgery. Antibiotics are a crucial part of the plan, but they are destined to fail without a radical debridement that physically removes the fortress.
So, where do antibiotics fit in then? Well, after the surgery, the therapy becomes incredibly targeted. And you'll notice one drug keeps popping up for staph infections, rifampin. And there's a good reason for that. It's one of the very few drugs we have with proven activity against bacteria inside the biofilm. We almost always use it in combination with another drug to prevent resistance, but it is a key weapon in our arsenal for mopping up any residual biofilm after the surgeons have done their work.
All right, let's make this real. Case number 1, an acute FRI. Picture this. A young patient has a nasty open tibia fracture. 10 days after surgery, their wound starts draining pus. The diagnosis here is a slam dunk based on clinical signs. This is an aggressive, early-onset infection, and the treatment has to be just as aggressive. It means an immediate trip back to the operating room for a radical debridement, taking out that intramedullary nail, and putting on an external fixator to hold the bone stable. Then, after we get our deep cultures, we start a long course of broad-spectrum IV antibiotics.
Okay, now let's flip the script and look at a chronic case. This one's a totally different beast. We have a diabetic patient who smokes, and they're 10 months out from a femur fracture that just won't heal. It's painful, but there are no obvious signs of infection, just some subtle hints on the X-ray. This is your classic low-grade, biofilm-driven infected non-union. The strategy here is a two-stage reconstruction. In the first surgery, we take out all the hardware, clean out the non-union, and put in a spacer made of antibiotic-eluting cement. Then, after about 6 weeks of antibiotics, we go back for a second surgery to take out the spacer and finally reconstruct the bone with a new implant and bone graft.
So, as you can see, treating these infections is just a monumental effort, which of course makes the ultimate goal even more critical. How do we prevent the siege from ever getting started in the first place?
You know, the best defense is a good offense. And in this case, our offense is prevention. And it's all built around this idea of a care bundle. This isn't about doing one thing right. It's about doing a whole set of evidence-based practices reliably for every single patient. Things like controlling blood sugar because high blood sugar impairs the immune system, and making absolutely sure those prophylactic antibiotics are in the patient's system within 60 minutes of the first incision. When you put all these things together, these bundles dramatically slash the risk of infection. But here's the thing. There's a huge systemic problem in how we even track these infections. There's a public health blind spot. See, reporting is all facility-based. So if a patient has their first surgery at Hospital A, but then months later their infection is diagnosed and treated at Hospital B, that infection often just disappears from the official surveillance data. This creates a massive blind spot, and it means we are systematically underestimating the true scale of the FRI problem.
And that brings us to our final section. We have to understand the true cost of this war. Not just for the healthcare system, but for the patients who have to live through it.
Financially, the burden is just staggering. The data is pretty clear. Treating a fracture that gets infected costs, on average, 4 to 6 times more than one that doesn't. And that's all driven by longer hospital stays, multiple complex surgeries, and months of expensive antibiotics.
But money, that's just one part of the story. The human cost is so much greater. Take this number, 9.2%. In one large study, that was the limb amputation rate for patients with a fracture-related infection. Nearly 1 in 10 patients lost their limb because the infection just couldn't be controlled.
And look, even for the survivors, the ones who get to keep their limb, the ones who are declared cured, the battle leaves these deep, permanent scars. Long-term studies show that years after the infection is gone, these patients report a significant and permanent drop in their physical health and their overall quality of life. The war ends, but the damage lingers.
And that brings us all the way back to the beginning, doesn't it? Back to that race to the surface. When the stakes are this high, the cost, the amputations, the lifelong pain, it really forces us to ask a tough question. Are we truly investing enough of our research, our technology, and our clinical discipline on preventing that very first bacterial cell from ever taking hold?